Hello, everyone. My name is Corey Thornton. I'm the senior editor here at Open Minds, and welcome to today's Circle Executive Roundtable, Sustainable Mobile Crisis Response, the Connections Health Solutions Case Study. Today's roundtable features Ryan Mattson, Director of Social Services at Connections Montana. He will be joined for the Q&A session by Open Minds Executive Vice President Karen Carloni. Before we get started, I have a few housekeeping reminders. Your audio is muted for today's roundtable. However, during the Q&A, we encourage you to submit your questions using the question box located on the right side of your screen. And finally, the slides and the recording for today's roundtable will be archived and available for all elite members on the Open Minds website starting tomorrow. And with that, here's Ryan.
All right, thank you so much. So thank you to Open Minds and Corey for inviting me to be here. I had the pleasure of speaking down in New Orleans, and I was invited to come share a little bit more about what Connections has been doing with mobile crisis here in Montana. So we'll go ahead and jump into it. So what we're hoping to cover today is I just want to briefly go over Connections, what the emergency state is of Montana's mental health system, talking about Gallatin County, where things had been, and what we're currently doing with mobile crisis in Montana. So real briefly, for those of you who are unfamiliar with Connections, it was founded in 2009 in Phoenix, Arizona. They opened up a second location there in Tucson, and it was actually started by those who pioneered the high acuity 23-hour observation model. And so we were lucky enough to have Connections come up to Montana as consultants originally back in 2022, and they were helping us to build some of our crisis systems. The county then reached out to them and asked them to take on mobile crisis, and we've been grateful for that. They've also started to expand into other states, and so here this year we've opened up a location in Chantilly, Virginia. We also just opened up Kirkland, Washington, and then we are going to be opening up Harrisburg here by the end of this year, so we're excited for that. We also have some anticipated locations, a second in Virginia and then a location in Oregon. Real briefly, again, some of the services. So while we only have mobile crisis in Montana, Connections does have a full spectrum of crisis care. And so the urgent care, 23-hour observation, the crisis stabilization, and then their transitions program. And so we're hopeful that some of those programs will eventually make their way to Montana. Because of the state of Montana and our behavioral health system, we were unable to get those started yet. And so when looking at Montana, I think that it's important to compare it to the rest of the country, especially when we're talking about the emergency state of its behavioral health system. And so looking at the suicide rates, as I'm sure a lot of us know, the rate for the US is about 14.3 per 100,000 individuals. For Montana, it's double that at 28.7 per 100,000. And so that's a big difference. And then another group that I think is important to highlight, which will play into some of Montana's challenges, is that American Indian Alaska Native group, which for that group, which is 25 to 44-year-olds, their rate is 52.8 per 100,000, which is just absolutely mind-blowing when you consider what the US national average is. And so looking a little bit closer at Montana, I'm often asked, why Montana? What is it about this place that's so beautiful that people love to come and visit that has such a high suicide rate? And so when we look at Montana, the population is very sparse, right? So we have 6.86 people per square mile. That's not a lot of people, and they are centrally located in some of our bigger cities in Billings and Helena, Missoula, Bozeman. And so there are parts of Montana where there is no one around you. There's a lot of isolation. Because of where we're located, there's also less sunlight. I'm not looking forward to this coming time of year where the sun starts setting around 4:30 and we won't see it again until the next day. But we have a vitamin D deficiency, which is correlated with an increase in depression. Because of our altitude as well, there's been a lot of studies looking at the metabolic stress, which impacts the body in a lot of different ways. And so it's important to keep all these pieces in mind. Now, any good statistician will tell you, right, that correlation does not equal causation, but there are a lot of pieces that are contributing. So we can't say that there's one specific piece which is contributing to our high rate of suicide, but there's a lot of pieces that definitely play into it. We also have a higher percentage of those high-risk populations. So for the white middle-aged men, we have about 80% or more, and for the national average, it's typically around 60. Veterans, we're about 10%. We do have a lot of veterans here in the state. National average is somewhere around 7. And already talked about the Native American group. We're here in Montana, we're about 6.5%, and national average is closer to 2. So for those high-risk populations, we have a higher density here within the state of Montana. We also have a lot of alcohol-impaired deaths, and it's my personal belief that a lot of those deaths and other substances, while not classified as suicide attempts or deaths, it would be appropriate to put them into that category. So I do think that we're still missing a lot of those people who are most likely dying, but due to a substance and their actions there. And then also access to lethal means. So within the state of Montana, about 68% of the suicides are with a firearm. And within the rest of the US, that's closer around the 50s. It depends on where you're at, but we have a much higher rate of access to those firearms, which is obviously more lethal and contributes to our overall deaths. And then looking more specifically at Gallatin County, so we've long been a ranching and farming community. My family's been here for a long time. One of my favorite stories to tell, which my mom absolutely hates, is about when she was a little girl riding her cow to her one-room schoolhouse, which just for me brings up the imagery of Little House on the Prairie and scenes like that. She gets mad because she says, Ryan, that was one time. But I love that story because I think it really helps show where Montana was at only a generation ago. Even my wife and I sent our son to a one-room schoolhouse for his first year of school, which is still there. There are rural schoolhouses around the state which still have students. And so we've seen this huge increase in growth, especially during COVID when people were wanting to escape the cities, have more space, work remotely. And with that, it's had a lot of challenges of increasing the housing costs. Our median is just under $1 million now for Bozeman, which is just absolutely insane for our community. And so it's really put a lot of stress on our local community. We also, when you look at Gallatin County as a whole, and that's the area that we cover as the mobile team, it is 120 miles from north to south. So everything from the Three Forks, Belgrade, Bozeman area down to West Yellowstone. You have to take canyon roads all the way up there, and it's over a 2-hour drive, and that's with good roads and good weather. And so it's a big area for us to cover as a team. I wanted to give a visualization of what it looks like within our state for where our closest resources are. So we have an inpatient behavioral health facility in Helena, which is our capital, and then we also have one in Billings. And both of those are, Helena's a little closer, about an 1.5 to 2 hour drive. Billings is about 2 hours. Between those two, it's a 239-mile drive. And so to bring that into kind of maybe something that other people would be able to understand, Washington, D.C. to New York is only 228 miles. So that's a huge gap that we have where there are no services for inpatient. And the services that we did have here in Bozeman have actually gone away. And so we're trying to rebuild those and fill those gaps. But it's a huge area where we don't have the services that are needed. And so when I was preparing for this talk, I wanted to pull up a lot of the articles that have been written just here recently within the last year about our behavioral health emergency. And the state as a whole is really struggling. Our state hospital is collapsing. They're now telling us that they can't even take individuals, and the way that our system works is those individuals are then released back into the community because we can only hold them for a short period of time. And so it's been a big mess for our state. And so our state hospital also lost its accreditation with Medicaid. And so our leadership at the state level has been scrambling, trying to figure out, okay, what can we do for the state? There aren't really funds that address these pieces. The state doesn't have the system set up to necessarily appropriately fund the programs. That's part of the reason why we lost some services. Montana actually doesn't have a sales tax, and so there's a lot of money that we don't get through that other states might be gaining that would be able to help support programs. And as I already mentioned, just the cost of living here has gone up dramatically. And so I think that it's important to really understand where Montana was, is to also look at where the system was. And so this might be similar to a lot of the states where you are at. What our system was here back in just 2017 is where we had one crisis worker covering 3 counties. We had an 8-bed crisis facility in Bozeman. And during that time, that one crisis worker would have to drive back and forth between those 3 counties. The wait time could be upwards of a day or more while you wait for that one crisis worker to show up and provide an evaluation in the hospital or the jail. Law enforcement was responsible for basically handling everything in the community, right? So they were the social workers, the peacekeepers, the counselors. There was a lot of burden on law enforcement. In the state of Montana, we also don't have a 72-hour hold. It's a different process. And so a lot of those mental health calls, even when the individual might be an imminent risk, they were oftentimes released back into the community because there weren't the services available for them. Also looking at our jail and hospital, we don't have dedicated services in our jail for behavioral health. Connections is helping in that area, but in terms of the jail employing its own staff, it doesn't have those. It does have some nurses and some other positions, but it doesn't have its behavioral health. The hospital has also previously had been contracting with an outside agency. They didn't have their own services, and so they were the ones that were having to wait for that one individual. And there were no long-term solutions. So we didn't have group homes, we didn't have ACT services, we didn't have anything to take that person from the crisis and help stabilize them for a longer period of time. So it was just staying within the crisis system and never being able to escape it. And this is what the model looked like. So you had an officer who was responsible to engage with that person in community. They were either going to take them to jail, which was often the quickest route. And I actually had a sheriff one time tell me that he wasn't interested in other services in the community because it was easier for him to take people to jail, see them there and deal with it. And that's just not the attitude that we want to have. But if they take them to the hospital, that officer may be out of the community for hours while having to sit on someone in the hospital waiting to be evaluated. Then if they do have to go to the state hospital, the way that our state works is that the sheriff's department then has to transport them. And for us, it's about a 2-hour drive. And so we just felt like the system wasn't working. We needed more resources. We didn't know what to do. We didn't really have much of a game plan, but I had been previously involved in a co-responder program in Colorado. And so I said, well, why don't we try to do co-responder here? And so while working with another agency, we developed a co-responder program and implemented that in the community. And while it had some benefit, it wasn't necessarily a strategic decision. We kind of just threw a resource into the community and hoped that it would make a difference. And we didn't have the staffing, so it was inconsistent. Law enforcement often didn't know when the individual would be working. And so it really had a mixed result. There were absolutely individuals who were helped by this program, but we weren't seeing the results that we were hoping for with this type of resource. And so this is what the model looks like when we had that co-responder program. So because it was a co-responder, they only went with law enforcement. There wasn't anything that they went out into community and handled on their own. Law enforcement was always with them. And so law enforcement was still tied up. So they're either still taking them to the jail, taking them to the hospital, or they're waiting with that co-responder for the couple hours that we're providing that evaluation. And it didn't really solve any issues. Yes, some people were able to remain in community, but with the lack of follow-up and no other services, people just went back into the emergency system, and it was, again, that cycle, and no one was really getting out of it. And so thankfully, the county took over the program and then asked Connections to take it over. And so in July of 2022, Connections was asked to take on what was the co-responder program at that time, and they transitioned it into a mobile team. And so the mobile crisis response team started officially in July of 22, but we didn't start full-time until about December or January of 23. And so with that though, Connections was very strategic in engaging the community partners. So all the law enforcement agencies, the help center, which manages our local 988 number, everyone was at the table, and we started discussing, okay, what is it that we need? What is it that we want this program to impact? And using data to make sure that we weren't just throwing another resource into the community and not being strategic about it. We wanted to make sure that we understood, okay, what is the impact right now on law enforcement? How many individuals are they seeing? What are the times that they're meeting with these people, so that we can make sure that our team is actually working during the key hours that law enforcement is having these behavioral health calls. We also worked on integrating into their system, and I think that this has been one of the biggest pieces for the success of our team, is having access to the CAD, which is computer assisted dispatch, and being proactive in staging for calls. We also have what are called run cards. Those are automatic pieces that are built into the 911 system, so that if a call type comes through, it automatically dispatches the team. And then also we had to look for different funding opportunities, because the program had initially been funded by the county and the city of Bozeman. They were the ones that were funding that program, but that program was also not 7 days a week. And so we really had to start looking outside of the county and the city to be able to fund it, because it just was not going to be a long-term solution for them to pick up that cost. So we started the mobile crisis response team, and what our team makeup is it's a two-person team. We have one therapist and one responder that work together. They don't separate, they don't go on separate calls. They're always together for safety and other reasons. And they are able to go out into the community, both dispatched through 911 and 988. This is our current model. So you have the individual who's in crisis, and they can select which method they want to reach out. If they want to reach out through 911, great. Law enforcement may be a part of that call, because maybe there's an imminent risk piece. There could have been an attempt, so maybe EMS needs to be involved, or they can also reach out through 988. Both of those can request mobile crisis, and then mobile crisis can respond both in person and virtually. So if there's it's never a no for our program, it's always a how. And if we have an individual that is unsafe for us to respond to in person, then we have the option through our EHR to actually send them a link directly to their phone or to their email. They click on that link and they don't have to download anything. It just automatically takes them into that video call with us. And so that is one option if we can't go in person. But it's always a how can we work with you? If it's not virtual, okay, can you go to a public location where maybe everyone is a little safer for us to come meet with you? And that's if law enforcement isn't there. If law enforcement is there, then they will clear the scene, and then we'll be able to come in, and then law enforcement will hopefully be able to leave and go back to the community and leave us with that individual to evaluate, resource, and safety plan with them as needed. And so once the team started, our first big question that really needed to be answered with law enforcement to see, okay, is this program actually successful, is how are we going to identify what is a mental health call? And this still comes up even when people ask me, what are the appropriate types of calls to request our team on? And I often just say, if there's a person involved, it's probably appropriate in some way or another. But that doesn't necessarily help the data to identify, okay, on these mental health calls, are we actually having an impact as a program? So when we're looking at 13 to 14,000 calls a month, obviously not all of those are mental health. So we need to figure out, okay, what calls are mental health to see, are we having an impact in terms of the time officers are having to spend on scene, the disposition, all of those pieces. And so which ones are mental health? So what we started doing is we looked at the data, and the way that our program works for law enforcement is they do have a box that they can check that says, hey, this is, you know, a mental health call, which is difficult to get people to check a box. But that's really a piece that we focused on with our law enforcement partners, is making sure that they're identifying the mental health calls, because a call may come through initially as a disturbance or a welfare check, and it may or may not be mental health. So we need them to be able to identify that separately. We also look at our involuntary holds, so what we call protective custody, of when an officer has to go and take a person on an involuntary basis because of their mental health. So it's either a danger to self, danger to others, or an inability to meet their basic needs. We also look at those calls that Gallatin Mobile Crisis, that's what our team is called, our call signs, GMC. And so when GMC is assigned to a call, then identifying those, and then we overlaid all three of those reports together and removed the duplicates. And what we found is that gave us about 50% of the mental health calls that are happening. So the question is, okay, how do we gather then that remaining 50%? And so what we did is we started doing keyword searches within the reports, and a lot of those were based around suicide and behaviors. So whether there was psychosis, whether there was a plan to kill themselves, any of those words that an officer might be entering into the system that we could then search for to try to get an idea of how many of those calls are getting beyond those initial three reports. We then overlapped those, removed any of the duplicates, and that's how we started pulling together all the data from the calls for service or the CFSs to figure out, okay, what calls do we need to be analyzing for data? This is an example of one of our heat maps that we use to identify, okay, where should the team be staging most often? So we wanted to make sure to be proactive that we, with a county as large as ours, we need to be centrally located to where those calls are most likely going to be coming from. And so looking at the data from 911, we were able to heat map, okay, where are the majority of those calls? And the big yellow section there is right on top of Bozeman. And so majority of our calls come from Bozeman, just north of that is Belgrade. And so that's where we tend to spend majority of our time staging and trying to be proactive in responding to calls. So when we are looking at the proactive response model, what we do is we will watch the system, and the team will look through calls that may be connected to mental health. So if we see a welfare check, we'll click on it and see, okay, is this a 2-year-old that's found wandering through the street, or is this an individual who reported to family members that they were feeling suicidal? Once the team has identified that, we will actually go and stage that call, and we will put into the CAD system that GMC is staged and ready to respond. We will also send a text message to that officer who's on scene and let them know that we are staged and ready. So that way they know that if they want our service, and it's still up to them, we don't crash the scene, they are still responsible for the scene, and we want to be respectful of that. But we want to make sure that they know, okay, when they are ready for us, we are just down the street, so that our response time is not 30 minutes because we're leaving from an office. It's actually going to be somewhere between 0 to a minute because we're just walking down the street to join them. Also, the benefits of this model allow for us to hopefully identify those individuals earlier in the crisis system and engaging with them before it reaches a mental health emergency. And so you typically wouldn't engage with an individual, say maybe through a domestic violence call, but we might be able to provide that behavioral health support before it reaches that mental health emergency because we were able to proactively engage in these types of calls. I already talked about the piece with us being able to be dispatched from 988, but that's a huge piece for me, is because we want people to have the choice. Is if they don't want law enforcement involved, they should be able to choose, assuming that they are safe and that it's safe for us to respond. If it's not, then obviously we can always reach out to law enforcement and ask them to accompany us on the call. But we want to make sure that if possible, we respond without law enforcement for that individual, but also to save a resource in the community where law enforcement has a lot of things that they need to be working on. We can't have them tied up in calls with us. Also, I had talked about how we are providing some services at the jail. Connections, even though the jail does not qualify as a mobile response, Connections has separately been providing those evaluations to them, because otherwise those individuals are left in the jail for days. They're transported up to the hospital to be evaluated, and then that takes a bunch of resources, not only from the hospital, but from the detention center. And so it was important for us as a good community partner to help fill that gap, but it's also helped support our team. We're also able to go up to the hospital and do transport, do warm handoffs, or if the hospital has someone that walk out, we can go meet that person in the hospital parking lot and do an evaluation with them there to make sure that they are safe. The biggest piece with this, though, is making sure that we are meeting the community where they're at. Of why are we taking resources to pull individuals out of their homes, wherever they feel comfortable, bringing them up to a hospital where maybe they don't want to go, when most likely we would be able to serve them at home in their system and provide them the resources to be safe. So people often ask about our funding sources. And so real briefly, we utilize braided funding. So we're a mixture of fee-for-service, grants, contracts, different pieces. And so the benefits, obviously, with the braided funding is having multiple resources to help support your program. I've yet to live in a state where we're able to have funding 100%. While I love the idea of the fire or emergency model where we're just fully funded and the team gets to go out on whatever calls, that's just not the reality at this point. And so we've had to work with those braided funding sources to make sure that we do have appropriate funding to sustain our program. One of the pieces that is important to consider, though, when looking at braided funding is the reporting requirements. So I do have to have, multiple reports that I send out to whether that be county or state or other partners who are funding us to make sure that they have the data, which they have contracted with us to make sure that that's being supplied. So there is an administrative burden when it comes to braided funding, and you want to make sure that you consider all of those different pieces as you're looking at funding. You also want to be careful with taking the grants that are for initial program startups. It might be good for a year or 2 years. You want to look at the requirements for reporting, but you also have to look at the fact that this money may be ending, and then what is your program going to do to sustain itself? And that's where we find ourselves a lot when we're looking at some of these grants that are coming out, is they're not meant for ongoing operations. It's meant for new program startup, and then you're kind of just left with, well, now what? So I definitely advise caution when looking at those and considering all the different pieces related to the braided funding. With that, though, looking at fee for service compared to others. So while part of what we do is fee for service, I think there's a lot of benefits to that model. It does allow for a lot of flexibility in the services that you're providing. I also think that it allows for the service to be a higher quality. One of my concerns with, say, bundled rates is that if there aren't guidelines set by the state which specifically outline how are you going to engage with this person, what is the service that you're going to provide, you then have the situation where people may not be providing the higher quality of service to an individual because it's not required. So my team, for example, when we're engaging with an individual, we perform a full evaluation, make sure that person has all the resources, we connect with collaterals. We spend a lot of time with that person. And if it was just a bundled rate of here is a lump sum for engaging with this person and there's no consideration of the extra pieces that we do, then we would actually be losing out on the funding based on the services that we're providing. There are benefits to the bundled piece. I typically look at those for longer term, for maintenance type programs. If you have to consider the acuity of the individual. And so if you are looking at some more complex advanced bundle models, then they may take in the acuity of the individual. And so these are things to be considering when you're working with your state around funding. Find the reimbursement model that will work best for your program and for the services that you're providing. Do they need to unbundle some of their services? For example, we call it PACT here in Montana, but the rest of the country calls it ACT. And it had a pretty high burden in terms of what the staffing model was. And if you didn't have one of those positions filled, then you had to break all those services out and bill as a fee for service for all the separate services, which was just absolutely insane and was a huge administrative burden. And so it was important to consider the fact that that bundled rate, while it might have been okay, if you're not able to fill a position, which is definitely hard in Montana, I'm sure it's a huge burden in a lot of other areas because of the lack of staff available, then you're going to have this huge burden of billing out for all those services. So it's important to keep those pieces in mind. I do think that the hybrid models that start looking at fee for service combined with some bundled payments is probably best. But again, this is just to give you ideas of those things that you might be able to take back to your state and say, hey, can we unbundle? Can we bundle? Can we combine services? What are we looking at? The other piece with finding the flexibility for your program is what are the staffing requirements? So for Montana, mobile does not require dedicated FTE. And so that's how we're able to have a contract with the detention center, is because our team is first and solely devoted, or not solely, but we're first dedicated to the mobile response. So if there's a mobile request, we have to go to that, but there is downtime. And so when we're experiencing that downtime, our staff are able to provide some of those additional services at the detention center. Are there going to be those populations that may be able to wait for you? So going back to the detention center, we have a population that is going to wait for us. And so we don't have necessarily the time restraints that we would have to get to them within, 30 minutes. We get to them as soon as we can, but if we're on another call within the community, that person may just have to wait until we can get to them. If someone else is able to go and evaluate them, great, but the jail doesn't have a lot of services available. They have one other contractor who helps provide those, but majority of the services are provided through connections. So that's one of the other ways that we help support ourselves. Also looking for those unconventional partners. So we're actually working with the county attorney's office to try and figure out, is there a way that we could have a position that helps divert away from the involuntary system? And so we want to make sure that we're looking in the community to not only find those gaps, but see how we might be able to work within that system to provide that resource to help support our program. We also work with private payers to make sure that they are open to us providing the service to their clients to make sure that they're receiving appropriate care. And so with those contracts, we have our response, there might be care coordination, case management. It's important to work with them to make sure that you figure out outside of Medicaid, who can we be billing for these services? Because my goal is to make sure that the individual is not receiving a bill for this. Because at least from my perspective, when an individual receives a bill for crisis services, that's most likely not going to help the situation. Now, there may be co-pays and other things, but there's a big difference between that and having to go, say, to the hospital and have to pay a couple $1,000s for that crisis evaluation. Making sure that you have a group that is advocating for you, and you may be that group initially, but working with your advisory councils, your coalitions, anyone in the community, working with NAMI if you have a local group, to help not only locally, but at the state level, be addressing the need that the community has, so that hopefully they recognize, okay, we need to have this service, we need to make sure that it's appropriately funded. Looking at the CPT codes, so I think that we can also be creative. Now, obviously, we're not, if you have to meet the standards, you have to make sure that all those pieces and boxes are checked. But if you're meeting the standard, then it might be beneficial to look and say, okay, with the services that we're providing, is there a better reimbursement code? Because say for my team, right, when we provide that full evaluation, we actually meet a standard that is different than a team who might just simply be resourcing or providing de-escalation. And so because we're providing that higher level of service, are there going to be codes that we can utilize to have a higher reimbursement rate because we're providing that additional service? Additionally, making sure that your staff are trained to use the appropriate codes, that someone is actually submitting them. One of the horror stories from working for another agency when we first started was going in and finding out that the billing department had boxes and boxes of paper billing that was waiting to be processed. and it ended up being about $200,000 that had just been sitting there for months. And so making sure that your billing department, your team are not only selecting the appropriate codes, but that the documentation supports it and your billing department is getting it out. So now getting into the research piece a little bit, this is a statement that JG Research and Evaluation, which is a local company that's actually contracted within the state to help our local coalitions and partners evaluate their data. And so with the numbers we're about to look at, we took June of 23 and 24 when mobile crisis existed from Connections, but we wanted to be able to compare it. So we had to pull a representative sample from June of 22. And so what this statement is just explaining what that sample is from all the pieces that we did to make sure that it was an appropriate representative sample. I won't go through all those pieces. Basically, this is to say that what we did was statistically appropriate and there's validity to the data that we pulled. So looking at the average time on scene with mental health calls that law enforcement spent back in June of 22, they spent on average 232.33 minutes on average per mental health call. So then when comparing that to the first year that mobile crisis came on scene, law enforcement then decreased to 72.82 minutes on average per call. And then the green there is the amount of time that mobile crisis was spending on scene per call. Then this most recent June, the average time law enforcement spent on call was 52.47 minutes. And so we had a reduction of 77.4% from June of 22 to June of 24. And again, the amount of time that the mobile team spent on calls went up a little bit, which isn't bad because we want to make sure that we're spending the appropriate amount of time to resolve the call so that it doesn't have to go back into the emergency system. So when looking at this data, this was a huge piece for us. But what's important to consider is when we first asked for this data to be pulled, they came back and said, well, actually, law enforcement is spending more time on average per call than what they did before mobile crisis. And so part of the piece that is important is making sure you get into the specifics of your data. So what I had to do is I had to go into each CFS or call for service and look at when an officer was assigned, when they arrived on scene, when they requested GMC, when GMC arrived, when the officer left, and then I had to compare all those numbers back and forth. It was a lot of work, but there's a big difference between saying law enforcement on average is spending 5 more minutes on mental health calls since mobile started versus law enforcement has had a 68% reduction in the average time they spend on these calls. So just because we're asking the question, it doesn't mean the data is giving you the right answer. It's there, but make sure the data you're looking to pull is actually what you're getting back. And if it doesn't make sense, then dig into the exact numbers and figure out, okay, what are we missing here? What's happened? And this is what we ended up with when we dug into that a little more closely. Also looking at the average amount of time on scene. So that's reduced over the last 2 years. So on average, going from 46 minutes to 30 minutes. And then the average time that it takes for law enforcement to request GMC after arriving on scene, from almost 50 minutes down to 18. And so what that shows me is that law enforcement recognizes us as a good partner and they're becoming more comfortable of those situations when they should be requesting us. And so then looking at our in-person services from July of 23 through July of 24, after the team is requested by law enforcement, how long did it take us to respond? And on average, it was 11.9 minutes for 441 services. And so this is including those long drives that we might have up to Big Sky that take an hour. It's because of our proactive staging, which has allowed for us to have multiple contacts where it takes no time at all. And so this is how you get that average of a good response time, is being proactive and staging, being ready to go, watching the CAD so that you can have that quick response time. Then just looking at all of our services since we started full-time in December of 22 through just this last month of August 24. So our total non-disposition services, those are services where we're not going to be determining where the individual is going. Do they need a higher level of care? Are they safe to remain in community? We had 1,318. Our total disposition services, so those evaluations, the care coordination, the de-escalation, where we're keeping them in community, having to decide, okay, do they have to go to the hospital or can we do a safety plan and keep them here, was 1,135. Those individuals who required a higher level of care was 155. Those that remained in community was 980. So our success rate has been 86% of being able to keep people in community when we go out and provide that evaluation or those services. National is around 70. And so our team has been doing just a phenomenal job of taking the time to work with people, releasing law enforcement to go back to what they were intended to do. Let us spend the time so that then we have this higher success rate of being able to keep people in community and hopefully help get them out of that cycle of engaging in the emergency system. This is just a graph showing the numbers from month to month, from March of 23 to August of 24. The lighter color are those that required the higher level care. This is looking at our referrals. And so with our different referral partners, connections is a big chunk in the middle, just because when we make a follow-up or we choose to engage with a person, that's our own internal referral. But otherwise, looking at all of our partners, I analyze this with them monthly to see, okay, are referrals down? Are we having any issues? Or are you not being able to contact us? Just making sure that we're continuing that conversation. This is looking at the jail evaluations. While we thought we'd only have a handful to start, we've actually had significantly high numbers, which has been a huge success in being able to support our program. And so specifically, what's next for the team? We want to expand to 24/7, 365. So right now we're a 12/7. So we cover every day, but it's a 12-hour shift. So we are 10 to 10. And consistency is a huge deal. Being able to cover that 7 days, Connections was the first program that was able to come in and cover that 7 days consistently. And since we did start in December of 22, we haven't had a single shift where we didn't have coverage, and which has just been great. We'd like to be able to include multiple teams so that we can respond to further out areas, spend more time. We also want to look on creating a system-wide tracking so that we don't lose people in those gaps. We want to continue to leverage our telehealth, and like I talked about with the county attorney's office, is adding that community support or that community diversion position to hopefully avoid some of those involuntaries. And then just real quick, the next steps as a community, we want to make sure that our data is easily read by those making decisions at the state and county levels, those people who are going to decide policy. Because if we can show with our data, not only are we saving you time and money, but that it's having this impact on the community, then hopefully they will look at supporting better, increasing reimbursement rates, whatever that might be. We're also, as a community, trying to figure out a referral system and also being able to a unique identity to be able to track people across the different systems so that we can see, okay, if mobile team engages with a person, does that actually help them stay out of the system, or are they just going to the hospital now? And so making sure that we're closing those gaps and providing the best service possible. And so just the key takeaways. I think that first you have to be able to identify what is a mental health call. If you're working with law enforcement and you can't say what a mental health call is, then you're never going to be able to pull that data to show what is the benefit of our program. How are we actually reducing officer time? How are we saving some of those FTEs? Using those partnerships and resources, using the CAD to expedite and to have that quicker response, making sure that our partners feel comfortable leaving us on scene. That's a big ask for law enforcement, to have a therapist and a responder come onto scene and say, okay, we feel safe, here you go. So building that partnership, making sure they feel comfortable, and then consistency, especially with your law enforcement partners. Excuse me. Consistency is key. You have to have consistency with your partners. Like I talked about, making the data work for you, getting into there, deciding what your KPIs are, and going and pulling out that data and making sure that that data is actually addressing what you're hoping to know. Because it's not, again, it wasn't that we had gained 5 minutes, it was that the mobile team was actually extending those calls. That's why we had that additional 5 minutes, because it wasn't getting cut up between officer time and mobile time. It was just looking at the whole call. So make sure that you're getting into the system and getting those precise pieces, making sure you know your system, mapping out all those, the entry points, where the gaps might be, and then where you might be able to put your team into to help supplement your budget, and then being creative with the funding. Most are using a braided source for funding, but make sure that you're advocating with the state for what is the best reimbursement model for you and your program. Are they able to bundle? Are they able to unbundle so you can do fee for service? Working with private insurance, and then making sure that you use those CPT codes to increase your reimbursement, making sure your team is trained well to enter the appropriate codes and that your billing department is getting them out. So that is what I have at this point. Thank you so much for listening. And Karen's going to join me now to help facilitate the questions.
Thanks, Ryan. This is Corey. We're having a technical problem on Karen's side right now, which we are rapidly working to fix. I'll get you started, Ryan, if you could. What advice would you have for executives maybe working in states that don't have the support that you currently do in Montana?
Yeah, so we were very lucky to have some very strong supporters, not only within law enforcement, but within our local government. But I think a lot of times it has to be grassroots, going back to finding, working with your local NAMI. Do you have a local advisory committee that is helping to support the behavioral health goals, any coalitions that are nearby? Because at least from my perspective, until you have multiple voices at the table, and sometimes it's who you know, and expanding that network. So if you don't have that support, then it's just making sure that that voice is heard. We used to go up to the state capitol and give public comment on different bills and all those pieces. And so a lot of times it's just that repetition of making sure that your voice is heard. Make it to where they recognize your face, of when they see you, they know, okay, well, here it comes. We're going to be talking about this piece, but they just have to hear it over and over. Our county does a kind of a luncheon for local representatives where we take, we'll feed them, but then we take their time and explain to them what the local issues are to hopefully get them to address what some of those budget pieces might be, what those pain points are. And so that's what we've done locally, which has had a lot of success.
Ryan, I was struck by the difference between providing this service in Montana versus Chantilly, Virginia, which is not too far from me. And I was wondering about how you thought about your staffing model in the urban versus rural area. What data did you pull? How did you think about the hours you were going to staff and how you're going to staff those two different jurisdictions?
Sure. So Chantilly actually doesn't have the mobile team. Chantilly is just for Connection to open a facility, but Harrisburg, Pennsylvania will be our location with the next mobile team. And so that team will actually be massive compared to my small little team here in Montana. So there we will actually have two teams operating 24/7. And so I'm really excited for what we're developing there. But again, it was looking at call load of what is your population, what are the call loads that you're looking at, that really drove that conversation. So the same process that we had here in Montana to figure out, okay, when does the team need to be working? We pulled the data and worked with our partners to figure out, okay, here's the call load. If you have one team, it's just not possible to cover this number of calls. And so again, going back to your law enforcement partners and asking them to identify, okay, what's that peak point? And they may not be able to pull all behavioral health calls, but they will be able to pull at least some. When are the most suicidal calls? When are you having domestic violence? When are you having these pieces? Looking at that time frame. But it's nice since we have the 24/7, then the time frame's a little less since we have them operating full time.
Thank you. One of our listeners wants to know, if you had to start this all over again from scratch, what would you do differently?
Hmm. It's kind of interesting because I feel like I have done this from scratch a couple times. So I first started a program, or I helped facilitate starting a program in Colorado where I was a co-responder in Larimer County, and then coming up here and starting the co-responder for Gallatin County. I feel like those were my attempts at realizing what were the mistakes made. And so starting over, I think that taking the appropriate time and first figuring out, okay, what is even the goal of this team? I think that a lot of times people feel like, okay, if we just add this resource, if we have this resource here, if we have this resource here, then the community will be fine. And I think that the addition of our co-responder program back from 2019 showed that's not the case. If you just throw a resource into the community but don't have that strategic plan, then it's most likely not going to have the impact. So spending the time with your partners to figure out, okay, what are you actually hoping this program is going to do for you? Because if no one knows, if they say, well, we just want them out there to meet with people, that's most likely not going to be successful, because what are we going to measure? And so spending the time with law enforcement, we were meeting with law enforcement, all those different agencies, so Bozeman, Belgrade, Manhattan, our college, MSU, the Gallatin County Sheriff's Office, the 911, 988, working with them consistently. I think there for a while, every week, every 2 weeks, then send it out to every month, but on a consistent basis, meeting with them individually and as a group to say, okay, what do you need from us and how can we get that to you? And I think that the only change I'd make is to continue to make that maybe a little stronger going into it. We got there pretty quick, but identifying what are those pieces they wanted from us.
Thank you. That's helpful. And then I was thinking about, I think a lot of our listeners would be really interested in hearing a little bit about your technology strategy, your needing to connect to the police, your need to collect your data, and making that as seamless as possible while you're out in the community doing mobile documentation and all of that.
Sure. So we have it's called a Tough Book, is the law enforcement computer. It's basically a brick. It's horrible, but that's what directly connects us to law enforcement calls. So we can see every call, which actually required my team to go through additional background clearance and training with CGEN for the criminal justice side of things for us to be able to see the law enforcement calls. But we can see every call. And so there's that piece of technology which allows for us to do that proactive staging. We then have our computers, which connect to our EHR and everything else that will do our concurrent documentation. We actually have portable printers. So if we want to print out a safety plan, if we need to print out anything else for them resource-wise, that's just coming out of our trunk, and we'll just print it for them right then and there instead of saying, well, we'll get this back to you. And so we have that as well. We have within our EHR, we are collecting some of those data points. We also use an Excel spreadsheet. I know it sounds super fancy, but sometimes I think that duplicating, especially as you're starting a new program, to make sure you're not missing data pieces so that I can compare, okay, what is it showing in our EHR versus what is the team saying they actually did, and being able to compare those two pieces to make sure that our system is set in a way that we're not going to miss any of those calls or any of those data points.
Thank you. That's really helpful. Also, I was giving some thought to some follow-along services. So once you've had a crisis call with an individual, are there any follow-ups that you do? Is there any kind of satisfaction data that you're collecting?
So we do a caring contact. So that's what we refer to it as. So that initial, within that first 24 hours after we've had that initial crisis contact with them, we're going to reach out to them and check in to see how they're doing. Okay, are they, still feeling suicidal? Were they able to connect with a family member to help support them? Any of those pieces that were still of a question, we'll also coordinate with them on trying to get them connected with resources. So, if it's 10 o'clock at night, we're not going to be able to schedule that therapy appointment, but the next morning when we come in, we can schedule that, work with it, and then reach out to them, make sure that everything's connected. So we'll handle all of those pieces as well through that. The state allows for us to track with a person and actually bill for care coordination for up to 14 days. And so after that initial crisis, we can have those multiple contacts. We do also have some individuals who are just those higher utilizers that we continue to engage in to actually keep them out of the system. It's not something that we can bill for. It's not something that's, you know, a fee for service, but it's good for that person and for the community, because we know that, okay, if you stop taking your medication, you're going to decompensate to the place of where you're having to go back into the state hospital, which we don't want them to go to. And so there are those multiple contacts. We currently don't have any surveys. You know, I've done those in the past with mobile, and it's, or excuse me, the co-responder, and it's always kind of that hard place to do. So we're still working on the best way to approach that, because we also don't want people to feel like, oh, you're only reaching out to me after the fact to gather data. And so it's finding that right place of in the midst, right? If this person's still upset, you know, they just had the loss of a loved one, it's really hard to pull out that survey and say, okay, would you mind filling this out for me? So there is a way to do it, but we want to make sure that we're sensitive and strategic about it to make sure that that person knows that they are the most important part of our interaction, and it's not just to collect data on the backside.
Thank you for that. And then that brings me to the thought about what are some best practices in providing these services? Are there specific modalities that you're thinking about, or the ways in which you approach your clients?
Sure. And so as much as I hate it as a therapist, right, there's the eclectic side of where we pull from everything now. If I had to narrow it down, we're definitely falling more into the solution-focused brief therapy side of things. Really identifying those goals. Where do you want to be? How are we going to get you there? Obviously, things from CBT, DBT, all these resources always get pulled in depending on who we're working with. If we are working with an individual who maybe has a personality disorder, say borderline, then obviously we're going to be pulling in more of those DBT things. And we actually just had a call yesterday where we were coordinating as a community around an individual who had been, you know, diagnosed with borderline, and we wanted to make sure that we were all on the same page so that one service wasn't going to ramp things up for that person, actually cause harm while everyone else is trying to follow the same plan. So on the most part, I'd say that I train my team, and I personally as a therapist fall into more of that solution focus. But there's not one specific one. I think that CBT is a great one for mobile as well, but there's lots of great models that have research behind them.
And then when you think about your kind of warm handoffs and the ways in which you help people find resources in the community, are there some things that you would suggest to organizations in terms of building those robust relationships with their community partners, and also managing any privacy issues that might come into play?
So the first piece in building the relationships, I strongly push for embedding your mobile team with law enforcement. Even though it's not a co-responder program, I have seen what happens when you have a team that is embedded and when you've had a team that's not. And so we embedded our team. The Bozeman Police Department was gracious enough to give us a space. Gallatin County Sheriff's Office has also given us a space. And it gets to the point where now they're actually, it's a little bit of fighting over who gets to have us the most. And it's a good place to be, right? You want to be appreciated by your partners, and you want it to be where they want you in your space, their space. But I think that's one of the first things, especially with the law enforcement side, is because it is such a different culture from what you typically see with, say, therapy. We have to earn their trust. They are dealing with life and death situations, and they have to know that, okay, if I call Ryan out on this call, he's not going to be a liability. Is he going to get in the way? Is he going to make it to where it's more dangerous for me as an officer or the people that I'm trying to protect? Is it just going to be that? And so they have to learn that we're not a liability. We're partners that they can trust and depend on. And that just takes face-to-face time. There's no other way to do it than other just over and over and over. And it also then allows for you to be a consult. And so officers are often coming into our office and just saying like, hey, you know, I had this situation, what do you think? And so it makes it much more of a community feel where they feel more comfortable coming straight to us, versus if we weren't there, that wouldn't be happening, and we'd just be the people that they sometimes call for.
Thank you so much. I really appreciate you being with us today, and I think that you have offered a lot of very solid tips that our organizations would appreciate.
Well, thank you so much for having me.
Well, Ryan, I also want to thank you. Karen, I want to thank you for jumping on. If you could please advance to our promo slide for next week. Okay, and everybody else, I forgot, I would like to thank everybody who joined us today for joining us. I want to remind you all that the slides and the recording for this will be made available on the Open Minds website starting tomorrow, and that you can join us next week on Thursday, September 19th at 1 p.m. Eastern for Expanding Substance Abuse Treatment, Reaching the 95% Initiative, R95 out of California. To register for that event or for a full list of upcoming roundtables, you can visit the Executive Roundtables page under the Executive Education tab located at www.openminds.com. Ryan, once again, thank you. You've given us a lot to think about, and I would like everybody to have a wonderful weekend.
Thank you.